This video is intended to offer information concerning the injection of a concentration of nucleated cells prepared from bone marrow aspirate as a treatment for critical limb ischemia. The video is divided into two parts. The first part describes the methodology for evaluating patient information in order to determine the optimum location for injecting this cellular concentrate, and the second part presents a specific protocol for performing the actual injections.
Hello, I'm Dr. Mark Iafredi. I'm the principal investigator for the Harvest Technologies protocol using autologous stem cells for the treatment of critical limb ischemia. Today I'd like to speak a little about the utilization of your imaging studies in helping plan your injections for this treatment protocol. As a prerequisite for enrollment, a patient must have adequate inflow into the leg. This angiogram demonstrates an essentially normal aorta and iliac arteries. It's mandatory that there be continuous flow to the level of the femoral artery for enrollment in this trial. However, iliac lesions can be treated with angioplasty and or stenting or bypass. Any revascularization option that restores blood flow to the level of the femoral arteries will result in the patient qualifying from that perspective for enrollment in the trial. In this study, we see a typical scenario of through and through flow on both sides, straight through the iliac and the femoral arteries. The injection strategy should be based on a combination of your preoperative imaging, which may include conventional catheter-based angiograms, MR angios, CT angios, or ultrasound. The specific imaging studies are left to the discretion of the local expertise. Preoperative marking should be done in the holding area when at all possible. This will allow appropriate deliberation and planning based on these imaging studies and based on the patient's clinical symptoms and the presence of tissue loss. The strategies outlined in the 4 cases which I will be presenting will review the ways to prioritize the injections and to space them appropriately. The study calls for exactly 40 injections in every case at a spacing of 1 to 2 centimeters between injections. The distribution of injections can be prioritized according to the medial distribution, the anterior compartment, or based on circulation in the foot itself. The 4 cases which follow will include medial-based approaches, medial plus anterior-based approaches, and approaches that concentrate on the foot. We will also discuss how to deal with an ulcer which falls in your plane of treatment. Based on your review of the patient's clinical symptoms, your imaging studies, be they MR angio, CT angio, or duplex, or conventional angiogram, combined with your physiologic assessments such as ABIs, TCPO2s, and PVRs, you need to have a plan for an injection strategy prior to entering the operating room. Looking at the angiogram of the first case, we can see the below-knee popliteal artery is patent, and at the takeoff of the anterior tibial artery, there is a proximal stenosis. The anterior tibial then nearly occludes and reconstitutes in the rest of the calf. The tibio-peroneal trunk occludes, and the posterior tibial and peroneal are absent. Here we can see the continuation of the anterior tibial artery onto the foot. However, it is of diminutive size passing the ankle. The peroneal and the posterior tibial are never seen to reconstitute. This patient had tissue loss at the great toe and medial aspect of the foot. The anterior tibial and dorsalis pedis provided no benefit to these areas. Therefore, in considering the injection plan for this patient, attention would be paid primarily to a medial-based injection along the the plane between the posterior tibial and the peroneal artery. This plane would be extended across the ankle over the foot to the area of ischemia on the great toe. In this case, our inflow through the popliteal to the level of the tibial-peroneal trunk was adequate. Our treatment needs to extend from the tibial-peroneal trunk, or within 2 centimeters of it, across the medial plane of the leg, across the foot to the great toe. The anterior compartment will not be addressed in this approach. Using ultrasound guidance, we'll find the tibial-peroneal trunk. It should be relatively easy to identify. And again, 1 to 2 centimeters from the termination of your feeding vessel should be the beginning of your injections in every case. Here, our distance from the tibial-peroneal trunk to the ankle is about 32 centimeters. Our line is made in the typical position that you would use for a medial approach to the posterior tibial or peroneal artery when approached surgically. We'd be moving off the edge of the tibia 2 to 4 centimeters in your usual surgical approach. The distance then from that spot on the ankle to the great toe is another 15 centimeters in this case. So we're going to want 40 injections along this 47 centimeter length of treatment, so about 11 millimeters each. We'll mark those preoperatively with our indelible marker. We'll mark out on our line every 11 millimeters down the entire length of the leg. When making these injections subsequently, ultrasound will be very useful in gauging the depth to your target. Although the area of the arteries will not easily be visualized by duplex, since obviously they're occluded, the accompanying veins should be easily visualized and should gauge your depth. So we can see here for our medial-based approach, we have a total treatment length of 47 centimeters. We have a total number of injection spots of 40 injection sites, and the injections in the operating room will be performed with ultrasound guidance to gauge your depth. This contrast angio runoff demonstrates a very different appearance in the right and the left legs. On the left, the superficial femoral artery is clearly occluded with reconstitution of the popliteal artery behind the knee. There is diffuse disease behind the knee, though there are geniculates which can be seen, and the below knee popliteal is seen to be quite a good quality vessel. On the right side, however, the superficial femoral artery is occluded, as is the popliteal artery above and below the knee, and all we see is a small hint of an area of reconstitution in the popliteal or potentially geniculate. Also of note, surgical clips consistent with the patient's prior vein harvest from his failed bypasses in the past. On the left side, we see the below knee popliteal artery is of quite good quality. The tibial peroneal trunk is patent, and there is nice two-vessel runoff through the peroneal and posterior tibial artery. The anterior tibial artery, however, occludes. The anatomy seen on this left side would not typically be appropriate for inclusion in this trial, as a femoral to below knee popliteal bypass would be a standard revascularization option. However, the right leg shows no reconstitution of named vessels. The vessel that was seen in the initial image is actually just a small branch and not a named vessel. With no named tibial vessels in the runoff and especially with prior vein harvest, this right leg is in fact appropriate from an anatomic standpoint for inclusion in the trial. Since there's no runoff, treatment would be based on a bilateral approach. Medial to reconstitute the perineal and posterior tibial distribution, and anterior to reconstitute the anterior tibial artery distribution. In this case, we need to combine a medial and an anterior approach to our treatment. Again, we have adequate inflow to the level of the tibial-perineal trunk, but this time all three of the tibial vessels are occluded with no visible reconstitution below. Therefore, we would again visualize the tibial-perineal trunk as in the right leg. You will then extend, as we previously did, our line for injection along the medial plane, generally 2 to 4 centimeters posterior to the edge of the tibia, as you would do for a medial approach to the posterior tibial or perineal vessels. We'll extend this behind the ankle and onto the forefoot. You'll then measure the length of treatment identified, which in this case is 42 centimeters, and move next to the anterior compartment. Here, you'll be looking for the origin of the anterior tibial artery, the spot at which it traverses the fascia. This also can be generally seen pretty well with your ultrasound by visualizing the anterior tibial vein. Marking the spot where this exits the fascia is generally at about the level of the termination of the tibial-perineal trunk, and it is in this case as well. We'll then move along the anterior tibial compartment, centered in the middle of the compartment, which typically very nicely overlies the anterior tibial artery. We'll bring this line down to the ankle, where we'll cross along the course of the dorsalis pedis artery and extend down onto the forefoot. So we have beginning and end. We'll use our measure to get an approximate length of treatment, and in this case 43 centimeters is measured. Total treatment length therefore is 85 centimeters. Given that we have again 40 injections which can be used for this leg, we'll divide our 85 by 40 and get about 2. Our treatment interval, our maximum spacing for this protocol, is 2 centimeters. So if we need to move up or down slightly to accommodate that, that will be done. Additionally, if there is an ulcer along our treatment course, we'll also space injections around that ulcer, and these will count toward your total. So in this scenario, if we spaced around our ulcer at our typical 1 to 2 centimeter interval, we'd have 4 injections here, leaving us with 36 for the rest of the leg. We'll take and mark those out at 2 centimeter intervals. In a case like this, where you ideally would like to be able to do more injections than you're allowed based on your constraint of 40, a little judgment is required to select the sites that you think are most important. If you need to move your injection plane up or down, you take into consideration the location of the patient's tissue loss, characterization of their rest pain, and where you think circulation would do you the most clinical benefit. Again, medially every 2 centimeters. So we have a total of 40 sites of injection, as we will in every case. In this study, runoff shows a similar pattern of diffuse disease but a patent artery in the superficial femoral artery right through the above-knee popliteal. As we follow the runoff below the knee, the popliteal is patent, though mildly diffusely diseased. The tibioperoneal trunk tapers quickly, and the posterior tibial and peroneal arteries occlude several centimeters after their origin. The anterior tibial artery also occludes just after its origin. These two legs in this pattern is consistent with that of thromboangiitis obliterans or Berger's disease. Regarding injection strategy for the left leg of this patient, since both the medial aspect and the lateral aspect, so the posterior tibial, peroneal, and anterior tibial arteries are all occluded with no reconstitution on distal runoff, treatment strategy would involve medial and lateral based approaches. Injections would start again within a centimeter of the end of the tibioperoneal trunk, possibly a little higher depending on the size of the patient and the injections that we need in terms of quantity, and would extend on the medial aspect of the leg and over the anterior tibial. This patient has severe three-vessel runoff disease, as in the last patient. What's different about this patient, however, is that he has ischemia over the medial aspect of his foot. He has no toe lesions, but does again have medial foot ischemia, much more pronounced than his lateral or his forefoot ischemia. Therefore, although we will again find our tibioperoneal trunk, mark the site, measure our distance, do the same over the anterior compartment, just as in the last case, mark the site, extend onto the foot. We'll measure these out, and since this is the same mock-up leg that we used last time, we'll use our same 85 centimeter treatment length. What we'll do differently, however, is we'll prioritize our treatment based on where we'd like to see the most revascularization occur. Since our primary disease is affected by this medial runoff, what we'd like to do is concentrate our injections primarily along this distribution. And the way that I'm going to accomplish that in this case is we're going to set a treatment length for this 46 centimeters of vessel at 1.5 centimeter distances. Therefore, if we're treating at 15 millimeter intervals on the medial aspect of the leg, a treatment length of approximately 45 centimeters is going to consume 30 of our injections. Again, 30 injection sites on the medial aspect of the leg at a distribution of 15 millimeters apart. That only leaves us 10 injection sites on the anterior compartment. The maximum space that can be used in this trial is 2 centimeter spacing. So we're going to start distally, since this is foot ischemia, and we're going to try to maximize our treatment in the area of the greatest ischemic gradient, and we're going to be able to treat 20 centimeters. So I'll measure back 20 centimeters from the end of this gradient, and here we'll be treating 2 centimeter intervals over the remainder of the leg. So 10 lateral, 30 medial, concentrating your injectate where you want your maximal benefit, remembering that your spacing is minimum 1 centimeter, maximum 2 centimeters. In this study, we see an aortogram in runoff. Access is via the left femoral artery, and on the right side, we see a mild stenosis of the distal common iliac artery. This is hemodynamically insignificant based on catheter pullback measurements, and therefore no additional treatment is required for this lesion, and the lesion does not represent an exclusion from the trial. The external iliac artery is normal. The common iliac and proximal superficial femoral arteries were patent, but the distal superficial femoral artery above Hunter's canal occludes. We see reconstitution of popliteal artery in Hunter's canal with reconstitution by very large profunda collaterals. The popliteal artery behind the knee remains patent. A nice collateral is seen medially here, and we extend distally to a tibial-peroneal trunk, which is of good quality. Continuing the runoff on this patient, the posterior tibial artery is occluded. The peroneal, however, is a robust runoff vessel providing anterior and posterior collateral branches collateralizing into the foot. Unfortunately, the collaterals don't significantly cross the ankle, and this patient presented with forefoot ischemia. Therefore, in considering the injection protocol for this patient, since our inflow is quite good through the peroneal to the level of the ankle, concentration will be paid on distributing the bulk of the injectate across the foot. We'll start within a centimeter of the termination of the branches of the peroneal artery and extend densely over the dorsalis pedis distribution as well as over the posterior tibial artery distribution. In addition, depending on the number of injections which have been consumed in this primary distribution, one would also distribute additional injections up the posterior tibial distribution, concentrating primarily on the distal aspect where the ischemic gradient would be considered the highest. So in this case, we have adequate inflow to the knee and below, despite the fact that the superficial femoral artery occludes. We see robust collateral flow into the geniculates, reconstituting the popliteal artery. That then follows below knee and reconstitutes our tibial vessels across the calf. In this scenario, what we primarily need to treat is the foot, and then when we have moved past that, we've decided that we'll treat back along the posterior tibial artery in order to create an improved gradient into the foot. So we'll start with the dorsalis pedis, and we'll trace up on the dorsum of the foot, again with ultrasound guidance if necessary, or just moving off the tendon. Then we will also trace the posterior tibial distribution across the plantar aspect, trying to work on the tarsal branches and around the ankle as our primary site of treatment. This is forefoot ischemia, and we want to concentrate our injections in the forefoot. If we find that we have additional capacity to use our 40 injections, we can continue up along the posterior tibial, but remembering that the forefoot is the primary target. So we'll mark out our primary targets. We'll bring our measurement in. And in our primary treatment zone, got 8, 20 centimeters for the medial aspect. An additional 13 centimeters for the anterior aspect. So we have 33 centimeters in the foot. To maximally concentrate our injectate here, we can space them at 1 centimeter intervals. So 1 cm intervals, and the same anteriorly. The injections along the dorsalis pedis cover 10 centimeter length We've spaced them at 1 centimeter intervals. 33 injections. That leaves us with 7. We're going to come along the posterior tibial distribution as we discussed, and here you have some flexibility. 7 injections. You may want to spread out to try to get the whole posterior tibial distribution. We can spread it to 2 centimeters per injection, which will get us pretty near the end of the tibioperoneal trunk. So we'll get our final 7 injections at 2 centimeter intervals, and we've concentrated the injectate in the area of the maximum ischemic gradient, in the area where we most would like to see clinical benefit, and then we have distributed the remainder of the injectate where we think there'll be additional benefit in terms of bringing the flow into the field. By way of summary, in determining your injection strategy for any individual patient, you need to consider the following 3 factors: preoperative imaging studies, clinical symptoms, and areas of tissue loss. Based on the approach chosen, the limb should be marked to diagram the approach and the specific injection sites, remembering that the therapy is limited to 40 injections with a spacing of between 1 and 2 centimeters. Because the study protocol restricts you to 40 injections, you may not be able to cover the entire leg. In this situation, you should use your best clinical judgment to move your injection plane up or down to treat the areas of maximal ischemic gradient. Thank you for your attention.
This section will offer instructions relating to the injection protocol for all study subjects. 40 injections will be delivered with spacing of 1 to 2 centimeters. The injections will therefore cover a linear distance of 40 to 80 centimeters, less if injections are placed around an ulcerated site. The approaches are similar to the surgical planes used for direct access to these target arteries. Typical approaches are as follows. 1. Popliteal artery, medial, paratibial, or posterior midline injections. 2. Tibial peroneal trunk posterior tibial artery, medial paratibial approach, inject at inner edge of the tibia. 3. Anterior tibial artery, straight through the anterior compartment of the calf. 4. Pedal arteries, direct superficial injections based on angiogram. And 5. Peroneal artery, lateral approach passing just inferior to the fibula. 4 10 milliliter syringes with needles will have been prepared and presented on the sterile field when the treating physician enters the operating room. All injection procedures are performed with sterile technique and full barrier protection. Injections into the calf will be made with a 21 gauge needle at a depth of 2 to 4 centimeters and should be performed using the Z-track method. Place your finger on the skin surface and pull the skin and subcutaneous layers out of alignment with the underlying muscle. You should move the skin about 1 centimeter. Insert the needle at a 90-degree angle at the site where you initially placed your finger. Inject 1 milliliter of volume and withdraw the needle. Remove your finger from the skin surface, allowing the layers to return to their normal positions. The needle track is now broken at the junction of each tissue layer, trapping the injectate in the muscle. While inserting the needle, draw back 0.5 to 1.0 milliliters on the syringe to prevent intravascular injection. Injections are ideally placed within 1 centimeter of the targeted vascular bed. Ultrasound guidance is used to localize injections. Although the target areas will typically have occluded arteries, the ultrasound may identify the popliteal or tibial veins, which are always adjacent to the native arteries. To minimize the risk of nerve injury, The injection is placed approximately 5 to 10 millimeters away from the neurovascular bundle. When tissue loss is present, several injections around the perimeter of the wound are indicated. Injections should be spread 1 to 2 centimeters apart. The needle will enter the skin 0.5 to 1.0 centimeters from the edge of the wound and extend under the wound bed approximately 80% of the radius of the wound. The injection will be made as the needle is drawn back to the wound edge, delivering a 1 milliliter volume of injectate. Injection into the foot should be performed with a 26-gauge needle. The injection sites are to be covered with sterile gauze and the leg wrapped loosely with a sterile gauze roll. If wounds are present, they will be dressed according to the attending surgeon's protocol.